Thank you very much. It's been an enormous pleasure to be here. This is my second time at Tata Memorial, and the quality of the meeting, and especially some of the very inspirational talks from this morning's sessions, were really some of the best that I've heard for a long time at a conference of this kind. I'm going to talk about the ethical imperative of accessible and affordable care, and I'm going to talk about it both from a point of view of rights, and I'm going to talk about issues of value and drug pricing. A right is a claim of entitlement supported by moral force, as distinct from a different sort of a claim. A right cannot be reasonably denied on moral grounds. Rights include obligations, which are duties to act, or sometimes protections, a right to be protected from someone else's action. The power of rights depends on the legal and political structure. Rights, however, highlight accountability, which may or may not be enforceable. Even if they're not enforceable, rights are generally sanctionable, and when there are breaches, they are always worthy of report. Human rights rest upon the central axiom that all human beings have equal moral status. And as such, all human beings are beneficiaries of human rights simply because they're human. And the implication of this, or the core concept, is that of a standard behavior. There is a reasonable minimal expectation that the international community or individual governments expect from themselves. There are two sorts of human rights: civil and political rights, which are essentially resource neutral, and I'll describe those, and socio-economic rights, which are often resource constrained and which are much more aspirational. So these are lists of what would generally be considered human rights: the right to life, freedom from torture, freedom from slavery, right to a fair trial, freedom from speech. And contrast these with the so-called socio-economic human rights. What you will see for all of them is that they are resource limited. Compulsory free education, freedom from hunger, freedom from poverty, right to a fair wage, right to safe working conditions, right to affordable health care. Some would even argue, and it is debated, as to whether these socio-economic rights are rights at all. And in fact, an argument is made that a right that can't be enforced is fraudulent and spurious, and that it's much better to relate to them as aspirational goals. And by referring them to as aspirational goals, the notion of fraudulence is reduced. Goals are inherently ability calibrated, and they can coexist happily with a low level of ability to actually achieve the outcome. We have a growing problem of healthcare inequality, particularly in the realm of anti-cancer medications. And in the developments of the last 15 to 20 years have seen two classes of medicines, which I'm going to demonstrate for you: medicine for the rich and medicine for the poor. And this has predominantly been driven by many of the new and expensive drugs, some of which have got substantial benefit, but which are driving substantial inequalities. Now, I'm going to share with you some as yet unpublished data from the European Society of Medical Oncology, which has looked at access to medicines across now something like 100 different countries around the world. I appreciate that this is a busy slide, and I'll explain it to you. This is looking at the cost and availability of some of the new anti-cancer drugs used in the management of lung cancer. Now, the top countries on the right are the wealthy countries of the world. The bottom group are the low-income countries, and these ones are the upper middle income and lower middle income. A blue box indicates that the drug is freely available. A green box indicates it's available at less than 20% of cost. A red box indicates that patients need to pay full price, and black is the drug is not available. And what you can see here is that across a range of drugs in the treatment of melanoma, you're seeing that essentially the new and effective drugs are available only essentially to the richest countries in the world. The same is true in non-small cell lung cancer. Again, a similar sort of pattern with increasing availability as one goes down the list. The value of any new therapeutic strategy is determined by the magnitude of its clinical benefit balanced against its costs. What we're aware of is that the costs of procurement and the out-of-pocket cost of consumers varies from country to country, but the magnitude of clinical benefit is a relative constant. And this is part of the reason that incentivized the European Society of Medical Oncology to start looking at the magnitude of clinical benefit of drugs to be able to indicate which are the really high-benefit drugs which are able to deliver a lot of benefit to patients, and which are the drugs that we're looking at marginal medicine with really borderline levels of benefit actually accrued. This is a very elegant slide which was prepared by Tito Foglio, who's in the audience here, looking at the range of drugs approved in the last 10 years and looking at the thresholds for approval. And what you can see is that for the majority of new agents have actually been approved on the basis of relatively low thresholds of either overall survival gain or progression-free survival gain. So there's a real need to sort the wheat from the chaff. When the magnitude of clinical benefit scale was applied, we've been able to sort out drugs into drugs that are really providing a high level of benefit compared to those that are scoring a very low level of benefit. And I'm not going to run through the details here. Furthermore, the drugs are evaluated not per drug, but rather per indication. And there are some situations where a drug such as erlotinib can have a very high level of benefit in one setting, in the setting of EGFR mutated non-small cell lung cancer, but a very, very low level of benefit in another licensed indication, such as in the management of patients with pancreatic cancer. We've also seen that the value of a medication in a specific indication can diminish when you have an improved control comparator, such that when we saw that when the value added for bevacizumab to ILF scored a 3 on the scale, when you compare the benefit, the added value for bevacizumab in colon cancer, when the basis is to FOLFOX, the level of benefit is 1, if at all. And finally, the value of a given medication can, in a specific indication, can improve with the better identification of a target. So when one limits the target to patients who are pan-RAS and RAF wild type, the value of the addition of panitumumab increases. I'd like to point out 5 salient points regarding value, cost, justice, and affordability. Firstly, we all suffer from the American healthcare system. Manufacturers' pricing for medications are strongly influenced by the medical laws, the Medicare laws in the United States, which compel Medicare to provide medications at the nominated drug company price without negotiation. Since Medicare constitutes 7% of the world market, this then becomes the benchmark. In this context, there's a total suspension of market forces and a disconnect between cost of medications and healthcare outcomes, and it incentivizes companies to price the drugs at the highest price that the market will absorb, and that this has a flow-on effect for the rest of the world. Over the past 15 years, the average cost of a course of therapy of a new agent has increased by 450%. However, the average duration of benefit delivered by these medications has increased by only 1/10 of that amount, about 30 to 40%. Furthermore, The progressive increase of medication costs over the past 15 years has made the pharmaceutical industry the most profitable of all the main industrial sectors in the United States and Europe, and the oncology sector is by far the most profitable of all of the different pharmaceutical sectors. And as I related before, that the price of new medications is totally unrelated to the magnitude of benefit. And another interesting and important point, on average, the industry budgeting for marketing is 2 to 3 times the budget for research and development. To say that these drugs are expensive because of the investment in research and development is misleading, because they're actually spending more than twice that amount on marketing. In the world of business, there is no ethical imperative to value. Business and healthcare ethics are different. Healthcare ethics are bound by a fiduciary relationship and axioms of beneficence, non-maleficence and justice, which leads to the concept of fair and reasonable pricing for services. Business ethics, however, are not bound by beneficence, non-maleficence and justice. Rather, they're bound by optimizing investor returns, and this can lead to concepts of unfair pricing, profiteering, and exploitation. It's been argued that despite the difference in these moral paradigms, pricing can often be influenced by appeals to fairness and justice, that moral force can be, and an appeal to justice can be applied by highlighting concerns regarding exploitation and the social responsibility for fair pricing. And we have seen examples of this, particularly with the availability of antivirals or treatments for AIDS and antivirals in the treatment of hepatitis C. We have not yet seen the power of this substantially exerted in the pricing of anti-cancer medications. There are harmful consequences. There is a high incentive for the pharmaceutical industry to produce new therapies that may show only marginal improvements. We have an enormous international strain on sustainability, with greater and greater need to ration reimbursement or to involve greater patient participation in cost sharing. And this burden is falling hardest on patients with incurable disease. And as I pointed out, this is contributing to profound inequality of access problems all over the world. Promotion of value is going to require a commitment to just pricing, and just pricing is a price structure that reflects the magnitude of patient benefits and value that ensures reasonable profitability and adequate incentives for research and development. It is not clear that industry can self-regulate. And models to promote just sharing have included risk sharing, which we've heard about, value-based pricing, differential pricing, trading, patent protection for reduced pricing, and in some instances, including in India, the use of compulsory licensing, whereby a patent is suspended for a token fee, and the right to produce the medication is transferred to another body. Aspirationally, the WHO Essential Medicines List was an international effort to try to create a much more just system, at least with the provision of basic medicines to be available to all, freely available, and certainly available on formulary. But even in the context of non-expensive medications, this is leaving us falling short. And what we can see, this is the range of drugs from the Essential Medicines List. What is striking on this presentation is when you look at the lower middle income countries and the low income countries of the world, even the Essential Medicines List is not protecting them and giving them access to free medication. So we have a substantial way to go to achieve what I would describe as the aspirational goal of affordable care, but I think that it is an overreach probably to call it a moral right. Thank you very much.